Good evening, all of you. So welcome to this INI-CET IBQ series, image-based question series in dermatology. So I'm your dermatology faculty, Dr. Jazeer, and today I have collected multiple images, which is very important for you during your preparations for your INI-CET, and we will see how we can prepare based on these image-based questions. So without wasting much time, if anybody could confirm if I'm properly audible and visible, then I can just get it started right away. To get things started, so let's start with the first question of the day. And this is going to be the first question. Now, identify the given image. So since we are dealing with the image-based questions today, what you have to do is just identify the image, key what exactly is this, and then give me the answer whether it is a Merkel cell or a keratohyalin granule or Odland body or a Birbeck granule. So very good evening, Gaurav and Dr. Dharmesh. You're very right. This is going to be the Birbeck granules, right? So what is a Birbeck granule? So these are Langerhans cells. Very, very good. So these are Langerhans cells. So just one thing that I would like to add on to this image is whether is it a normal microscopy or is it an electron microscopy? That can also be a confusing question, right? So Gaurav is answering ki this is our tennis racket shaped cells or Birbeck granules. Yeah, Rashmi is answering that this is seen in Langerhans cell histiocytosis. Amazing. So all these are right. And please remember, this is a electron microscopy finding. Okay, this is the electron microscopy finding. Amazing. Okay, right on the spot. Okay, amazing. Very, very good answer. So now let's see what is the next question. So there is an inflammation of the lobules of the subcutaneous layer, as which is labeled in the diagram, and this will lead to. So what the question here is, if there is an inflammation somewhere here, which is called as the subcutaneous lobules, what can it lead to? Is it a lipoma, which is a benign tumor of a fat cells? Is it erythema induratum? Is it erythema nodosum or erythema multiforme? So what is the right answer going to be? Who can answer? So I'm just waiting for your answers in the chat box. So just let me know what is the right answer here. So here there is an image of the subcutaneous layer of the skin, and there is an inflammation of the subcutaneous lobules. Lipoma, no, lipoma is actually a benign tumor, isn't it? So it is a benign tumor. So if it is a benign tumor of the fat cells, see the question. The question is asking you about the inflammation. So what is the inflammation of the lobules? I guess there is some confusion. Some of them is A, some of them is B. But Dharmesh, you got it right. This is going to be erythema induratum. So please note down कि अगर there is a inflammation of this area, that is of this side, that can be erythema nodosum. Clear? So if there is an inflammation of the fibrous septa, it is going to be erythema nodosum. If there is an inflammation of the subcutaneous lobules, it is going to be erythema induratum. I hope all of you are getting it right. Done. And let's move to the next question now. What is the wavelength that is used in the given device for dermatological investigations? Now what you see here, you can see here that there is some device, and this device is being put onto a skin where you can see that there is some red color fluorescence that is coming out. So this is a test which is going to give you some fluorescence from the skin. So what is the name of this device? This device is called as the Woods lamp examination. So this is called as the Woods lamp. So when there is a Woods lamp examination, the question is, what is the wavelength? Wavelength, again, is it B or is it C? Okay, please remember the wavelength of Woods lamp is going to be 365 nanometer. Okay, this is an instrument which is used to diagnose a lot of dermatological diseases. And in these dermatological diseases, what happens? The diseased skin is going to show you a colored fluorescence. Sometimes red, sometimes green, sometimes blue. So based on these colors, we'll be able to make out the diagnosis. Okay, so Nasrina is saying that this is again a Woods lamp, and she has answered it right as well. It is 365 nanometer. Excellent. So now let's go to the next one. So now let's see this question. that based on your understanding on the given Woods Lamb examination, which means again a question on Woods Lamb, which among the following is the most probable diagnosis? So first, before we look into the options, let's see the image now. So from this image, what we understand is this is an image of the groin area, and both the sides of the groin is showing some red color fluorescence. So which is a disease where you can find a coral red fluorescence? That is a question here. So where do you find a coral red fluorescence? So coral red fluorescence. So this, is it seen in pityriasis versicolor, vitiligo, tuberous sclerosis, or erythrasma? Yeah, all of you are answering it right. I guess all of you have studied the tables where you find different fluorescence, and this is going to be erythrasma. Excellent. So Harita, Rashmi, Dharmesh, Nasrina, Gautam. So all of you are who are answering it right. So this is seen in erythrasma. Amazing. So now let's move to the next question. There is a child who presents with multiple vesicles over the lips. What is the most probable Tzanck smear finding? So there is vesicles underneath the lips, and if there is vesicles underneath the lips, पहले ये बोलो कि diagnosis क्या होना चाहिए? So diagnosis should be herpes labialis, right? So this should be herpes labialis. So once the patient is having herpes labialis, which is caused due to herpes simplex virus, can we see a Tzanck cell? Can we see a multinucleated giant cell? Can we see Cowdrey type A bodies or Henderson-Peterson bodies? So yes, yeah, all of you are telling it as herpes. But ये बोलो कि what is a Tzanck smear finding? Okay, yeah, the Tzanck smear finding here should be multinucleated giant cells, because in multinucleated giant cells you must be remembering the examples. These are the examples, that is HSV as well as in varicella. HSV as well as in varicella, we will be able to see these kind of multinucleated giant cells. Can you tell me where do you find Tzanck cells? Option A. Yes, please. Just try to push yourself. Where do you find option A, that is Tzanck cells or acantholytic cells? Tzanck cells or acantholytic cells is again a very important finding in this investigation called Tzanck smear. So this can be seen in pemphigus group of diseases. Dr. Depaki is answering it right. So this is seen in pemphigus group of diseases. Okay, this is seen in pemphigus group of disease. So here the right answer was multinucleated giant cells. Super. Excellent. So these are some of the images for you. So the first image is showing you a multinucleated giant cells, and the second image is showing you that there is a acantholytic cells. You can see rounded cells with a large nucleus. So those are seen in pemphigus group of diseases. Clear? So now let's move to the next question. So whoever is answering it right, yeah, it's not only vulgaris, because Dr. Depaki, I told you pemphigus group. Pemphigus group matlab pemphigus foliaceus, pemphigus vulgaris, pemphigus vegetans. So all those comes under the pemphigus group of diseases. Okay? So now let's see the next question. An examination of a skin scraping from a 35-year-old male is shown below. What is the probable diagnosis? So here there was a skin scraping was done. So this is the image where I can see there is a large hypopigmented patch probably over the trunk of the patient. So if we do a scraping from this area and you see something like this, so this scraping, what I can see is that there are long strands as well. So these are all long strands of fungus, and there are multiple rounded lesions as well. So what are these long strands and these rounded balls? So this can be compared to these are the hyphae as well as the spores, which we usually compare to a banana and grapes or spaghetti and meatballs. So where do you find? Yeah, the chat box is all filled with answers. Excellent. So where do you find them? We find them in tinea versicolor, which can be caused due to Malassezia globosa or Malassezia furfur. So here the right answer is going to be tinea versicolor. Amazing to see all of you answering it right. So very good. So now let's go to the next question. So in this next question, we can see that the question is about identify the nail disorder that is shown in this image. I'll just zoom this image for you before we go into the options. First, whenever you're doing any image based questions, always try to answer it yourself कि ये क्या हो सकता है, what can be the cause, and then look into the options. That is a much better way. Otherwise you may get confused, right? So यहाँ पे what you see, yeah, so यहाँ पे you can see that there is something like this. So there is a yellowish discoloration, probably a pus. So this should be a infection of the lateral nail fold, isn't it? Infection of lateral nail folds. So what do you call for infection of the lateral nail fold? Is it leukonychia, paronychia, pterygium, or koilonychia? Yeah. So Tom Shubra is also answering कि causative भी क्या है? So she's answering कि it is going to be Staphylococcus aureus. So exactly, so this is going to be paronychia. So in paronychia, this is usually caused due to a bacteria which is called as Staphylococcus aureus in cases of acute cases. So this is going to be the right answer here. Okay. So now let's go to the next one. So in this question, we can see that oil drop sign. So the question is saying very clearly what is a sign, and a image is also given. So in which disease can we see a oil drop sign? So that's a question. So yes, I'm just giving you more time so that everybody can answer. So yes, the correct answer here is psoriasis, because in psoriasis, this is the most characteristic nail finding. Am I right? So the most characteristic nail finding that you can see in psoriasis is going to be the oil drop sign. So that is the reason why all of you are getting it right. Amazing. So now moving to the next question. So in this next question, you can see that there is a 30-year-old patient comes to your clinic with complaints of shallow, regular pitting of the nails. This condition is commonly associated with options are Lichen planus, psoriasis, tinea unguum, alopecia areata. So what is the right answer here? Yes. So whenever you find these kind of depression over the nails, and these depressions being regular and shallow, it is very, very typical for alopecia areata. Yes, and Dr. Depaki is giving the right explanation as well, because when it comes to psoriasis, we see the exact opposite. That is, we can see a irregular and deep kind of a nail pitting in this case, in the exact opposite way, right? So here the right answer should be alopecia areata, because we see a regular and shallow nail pitting. So with this MCQ, you learn two examples of nail pitting. एक हो गया alopecia areata, the second one is psoriasis. Okay, so now let's go to the next one. Chalo. So in this one, you can see that there is a 28-year-old lady. She presents to your clinic with complaints of a itchy skin-colored papule over the axilla. So थोड़ा lengthy question है, but then there are multiple clues here. There is a itchy skin disease, and this skin disease is seen over the axilla, and she does not have any complaints of hyperhidrosis. So I will just zoom this image for you. So in this image, what do you see? There are multiple papular lesions, and these lesions are seen over the axilla of the patient, right? So in this case, what is the diagnosis going to be? Options are Fordyce spots, Fox Fordyce disease, erythrasma, and hidradenitis suppurativa. Who can answer? Because I can see multiple answers now. Let me see who is getting confused here because of Fordyce and Fox Fordyce. Chalo, let us rule out erythrasma, because erythrasma doesn't present like this. Neither it is hidradenitis suppurativa. So most of you are answering it as Fox Fordyce, which is the right answer here. Okay, and then why is this Fordyce given? Just to confuse you. So what is Fordyce spots? Fordyce spots means that here you can see this is a condition of ectopic sebaceous glands. Okay, ectopic sebaceous glands can be seen, right? Yes, Fordyce lips, and also Fordyce which you can see over the genital area. All those things can be seen. Very good. So hidradenitis में तो bridging वाला, excellent. Debaki, that is also correct. Okay, that is seen in hidradenitis suppurativa. That is also a disease of apocrine sweat glands, right? So now let's see this MCQ. A 35-year-old patient complains of redness of the face. Redness of the face. She also complains that there is some hot flushes on consuming hot and spicy food. Very, very typical history. So where do you find this? Yes, rosacea, rosacea, rosacea. So everybody is going for the same option, that is rosacea. Because whenever you get a patient who is having a red face, especially with complaints of flushing, hot flushes, that happens with hot and spicy food, or it can happen with alcohol, isn't it? Or it can happen with hot beverages like tea or coffee. So in all these cases, the right answer is going to be rosacea. It's a very typical history, and that is the reason why here the answer is rosacea. So now let's do the next question, a very, very important topic in dermatology. So just when you see the image itself, you know the diagnosis. First, read the question. 25-year-old male presents to a clinic with symmetrical erythematous plaques with silvery white scales over the elbow. So ये कौन सा what is the area? This one, this is going to be flexures है, extensor है. So this is going to be extensor surface, right? So what is the diagnosis? All of the following may be seen except. So let me just zoom this. So this is a typical image of psoriasis, isn't it? This is a typical image of psoriasis. So the question here is, what may be seen except? So do you find Koebner's phenomenon in psoriasis? So do you find Koebner's phenomenon? Matlab, new lesions appearing at the site of trauma. Of course, this is seen in psoriasis. What is Auspitz sign? When you scrape the lesions of psoriasis, the patient will show some multiple bleeding spots, right? So that is also seen in Auspitz sign. Next one is scalp involvement. Do you find scalp involvement in psoriasis? Yes, scalp involvement is seen in psoriasis because you must be remembering the differential diagnosis can be dandruff or seborrheic dermatitis, right? Dandruff or seborrheic dermatitis. So what is the odd one out? Yes, yes. So the odd one out here is trichrome sign. But when you see this trichrome sign, it is also important key you have to tell me ki where do you see this trichrome sign. So this is what you call as a trichrome sign, and you see this trichrome sign in which disease? Can anybody answer what is the disease where you see trichrome sign in the chat box? So you see this sign in a disease called vitiligo. In a disease called vitiligo. In case for your exam, you get the image what you can see here. So in this image, what is the diagnosis? Dharmesh, that is seen in vitiligo. Amazing. So what about this one? What is the name of the sign where you can see pinpointed bleeding spots, especially which appears after scraping the lesion? Yes. So this is called as Auspitz sign. This is seen in psoriasis as well. So all these are important images. You must be seeing multiple images now as we discuss more MCQs. I hope none of you are getting confused. Okay. If there is any questions, please feel free to inform me. Okay, done. Done. So now let's go to the next question. A 35-year-old male presents with deep-seated pustular lesions over the palms and the soles. Very importantly, these pustules are sterile on examination, which means there is no growth of a bacteria. There is no growth of a fungus as well. The sterile pustules over the palms and soles. Is it lichen planus? Bilkul nahi, because lichen planus usually presents with violaceous papules, right? Or plaques, violet color or purple colored things. HSV can present to you with pustules, vesicles. HSV, thank you, Rashmi. So HSV, it usually presents with vesicles, not pustules. So please pay attention. This MCQ is asking you if the patient is having pustules. Next option is palmoplantar psoriasis, and the last one is contact dermatitis. Now tell me what is your answer. Yes, Dr. Depaki, that can also be seen in vitiligo. Yeah. So this is going to be palmoplantar pustula psoriasis. Remember, pustula psoriasis, you always get a pustular lesion which is going to be sterile pustules. Okay, sterile pustules. So whoever is asking C with a query, so please be confirmed. C is the right answer here. Now let's go to the next question. So in this next question, a 35-year-old male presents to your clinic with complaints of a 5 centimeter annular lesion. So you have to pay attention कि there is a 5 centimeter round or annular lesion followed by eruption of similar smaller lesions throughout the trunk. On examination, the patient shows a Christmas tree pattern and it was diagnosed as Pityriasis rosea. अरे यार इतना time तो बर्बाद किया है ना, because they have given us the diagnosis also. So ये जो annular lesion होगा, that could be herald patch and then multiple smaller lesions over the trunk, and now diagnosis is Pityriasis rosea. What is the infection likely associated? HHV7, hepatitis C, hemolytic streptococcus, or Epstein-Barr virus. So yes, half-wit, Dharmesh, Debaki, Rashmi, all of you are answering it right. HHV7. So please remember, pityriasis rosea is a condition which can be due to either HHV7 or HHV6. Okay. So what is the disease that is associated with hepatitis C in dermatology? Hepatitis C, it should be lichen planus. Okay, it should be lichen planus. And is there any disease, especially a papillosquamous disease, which can be associated with a group A beta hemolytic streptococcus? Anyone? Streptococcus. Remember acute guttate psoriasis? Acute guttate psoriasis. So psoriasis is associated with group A beta hemolytic streptococcus. And in dermatology, what could be associated with an Epstein-Barr virus? If you want a clue, it can be something that's associated with the tongue finding. Come on, just try to push yourself. Just try to remember what you have learned. So Epstein-Barr virus, yes, this can be with oral hairy leukoplakia. Leukoplakia, because this can be seen in patients with HIV, right? So here this Epstein-Barr virus is associated with oral hairy leukoplakia. Okay, so multiple things we are revising with these kind of image-based questions. So now let's go to the next question. The next question says, there is a 40-year-old male who presents to a clinic with multiple itchy purple colored papules and plaques over the flexures. So flexural aspect of the wrist shows purple colored papules and plaques. What is the most probable diagnosis? Yes. So all of you are now answering. ये तो हो गया. The 6 P's of lichen planus, right? So you can see that there are purple colored, pruritic, papules and plaques that can be seen in lichen planus. So very typical image of lichen planus. So please don't make a mistake here. Yeah, plain, purple, planar. Yes, bahut sare P. That is lichen planus. Okay, nice. So now let's go to the next question. So now we are just shifting from the lichen planus and psoriasis and moving to a new topic now. Which among the following chemicals is responsible for the skin condition given in the image? So now just zoom the image for you. So what you see here is, so in this image, I can see that there is a eczematous rash over the forehead. क्या हो सकता है? So is it? Yeah. So this can be due to bindi dermatitis. है ना? So bindi dermatitis is an example of allergic contact dermatitis. So in bindi dermatitis, what is the chemical that is responsible? So is it monobenzyl ether of hydroquinone, para-tertiary butylphenol, para-tertiary butyl catechol, or paraphenylene diamine? So remember P, T, B, P which is used as a gum in bindi, okay, gum or glue in bindi. This is usually causing allergic contact dermatitis or even chemical leukoderma associated with bindi. So here the right answer, like all of you have answered in the chat box already, like Asutosh, Depaki, Nasrina, Gautam, all of you are answering it right. This is going to be para tertiary butyl phenol that is associated with bindi dermatitis. So now let's see another question. Patch test is done for. So why do we do a patch test? If you want to see an image of a patch test, that is also given here. So great photography, right? It is not taken in the normal angle how we take. So this is showing a image of a patch test. So where do you do a patch test? So where do you do a image of a patch test? See, Dharmesh was asking कि कहाँ पे you see option number C. So PTBC, this can be seen in hair dyes. Okay, this can be seen associated with hair dyes. Okay, Dharmesh. So now let's see this question. So why do we do patch test? Is it for ICD? Is it for ACD? Is it for seborrheic dermatitis or nummular eczema? The correct answer should be allergic contact dermatitis. So whenever you are in doubt, ki the patient is having an allergy to a wristwatch, to a footwear, to artificial jewelry, to cement or anything like that, which comes under contact dermatitis, you can go for this test which is called as patch test and go for a patch test. So now let's go to the next question. So the next question says, a 10-year-old child presents to the clinic with complaints of multiple hyperpigmented macules. Okay, so you can see in this image also, you can see that there are multiple hyperpigmented macules, and the question says that stroking over the skin produced urticarial wheals. So if I just stroke over the skin, you can see that there is a urticarial wheal which is produced here. That is probably because stroking over the skin. And all the blood examination were normal except for increased serum tryptase level. What is the answer? Dharmesh is asking, is it diarrhea sign? Anybody else who would like to add to it? What is the name of the sign that is demonstrated? First, I'll tell you what is the diagnosis here. The diagnosis here is Urticaria pigmentosa. So what happens in Urticaria pigmentosa? In Urticaria pigmentosa, the patient will develop multiple urticarial wheals, and these wheals, they will heal with pigmentation. That is why the name Urticaria pigmentosa. And the name of the sign where you stroke over the skin and the patient produces urticarial wheals, this is called as diarrhea sign. This is called as diarrhea sign. So before we go to the next question, let us very quickly write down where do you find a dimple sign. Dimple sign is seen in dermatofibroma. And where do you find a Krove sign? Can answer? Where do you find a Krove sign? Krove sign is seen in genodermatosis. It's an autosomal dominant disease. Anyone who can answer? Krove sign. Krove sign is seen in neurofibromatosis. Very good, Omar. So this is seen in neurofibromatosis. Gautam Prakash is also answering. And finally, where do you find a buttonhole sign? Like you press on the skin lesion, the lesion goes beneath the skin, just like how you insert a button into a buttonhole. So this is also seen in neurofibromatosis. Dr. Depaki, Urticaria pigmentosa is not a misnomer. In dermatology, we have so many misnomers, but here you can trust the name. So because urticaria is produced and there is a residual hyperpigmentation as well. So that is not a misnomer here. Okay? So that is all about this MCQ. So let's go to the next one now. Identify the condition that is shown in the image. Is it angioedema? Is it urticaria? Is it angular cheilitis or herpes labialis? I'm zooming this image for you. So what do you see in this image? I can see that okay, there is a big swelling over the lips, and this swelling, it is not going to be anything else, but it is a typical image of an angioedema, where there is a swelling which can go towards the deepest layers of the skin, like the dermis as well as the subcutaneous tissue. So this is going to be angioedema. So typical spot diagnosis image. Okay. So we are discussing a lot of images today. That is why I'm just being very crisp and to the point in the discussion of all the MCQs. But whenever you feel that there is any queries, please feel to drop a message in the chat box. I'll be happy to answer you as well. So now let's see this next question. A 24-year-old male presents with excessive sweating and a yellowish staining of the inner vest around the axillary region. What is the most probable diagnosis? Erythrasma, axillary freckling, hidradenitis suppurativa, or trichomycosis axillaris. So I'll just zoom it. Yeah. So you can see that here the patient's axillary hair, you can see that there are multiple yellowish concretions or yellowish growths over the axillary hair, and the patient is also complaining that there is a yellow staining of the inner vest, which means the inner vest or the bunion which you wear inside, so that also is going to show you a yellowish staining over the axillary region. So what is the diagnosis? Does it happen in erythrasma? Actually, this doesn't happen in erythrasma. So in the chat box also I can see multiple things, C versus D. So please remember, this is going to be D, that is trichomycosis axillaris. So earlier some of you were asking whether it is a misnomer. Now this is a misnomer, because this name says trichomycosis, but this is not a mycosis. This is a bacterial infection which is caused by a bacteria which is called as anyone? What is the bacteria which causes trichomycosis axillaris? Would you like to go for something like Staphylococcus aureus, Streptococcus, or something else? Remember, it is caused due to Corynebacteria. So this is caused due to Corynebacterium, as Gautam is being very specific. Corynebacterium tenuis. So it is being caused by Corynebacterium tenuis. Okay, so that is the right answer here. Now let's move to the next question. And all of you, don't get confused with hidradenitis suppurativa, because I saw that many of you have answered it as C as well. So hidradenitis suppurativa, what happens? The patient will develop multiple nodular lesions over the axillary region, and there may be some interconnecting bridges as well. Okay, so it's an entirely different presentation what you have in hidradenitis suppurativa. So let's go to the next question. The next question says, identify the lesion. So what comes to your mind, or what comes to your things when you see this kind of an image, is there are multiple lesions, and in the center of these lesions there is a central umbilication. So whenever you see central umbilication and one lesion followed by the other, this is called as pseudo-Koebner phenomenon. It's called as pseudo-Koebner phenomenon. And this central umbilication, this one, that is what you see as a central umbilication. So this should help you to reach out to a spot diagnosis, that is, yes, molluscum contagiosum. Excellent. So I guess this was an easy question, right? So everyone has answered it. Dharmesh, Nehal, Rashmi, Gautam, Shruti, Depaki, all of you, Ashutosh. So this is called as molluscum contagiosum. It is a disease which is caused due to a pox virus. It's caused due to a pox virus. So now let's go to the next question. A 45-year-old patient has grouped vesicles on T10 dermatome and it is associated with pain. What is the most probable diagnosis? So you can see that the patient has developed multiple vesicles and there is a background erythema. And very importantly, what is the most important catch here? This is along a T10 dermatome. So is it herpes zoster? Is it scabies? Is it herpes simplex or dermatitis herpetiformis? Yes, very good. So all of you are getting it right. This is seen in herpes zoster. So in herpes zoster, which is also called as shingles, this is a reactivation of varicella virus, right? So when there is a reactivation of the varicella virus, this is called as herpes zoster or shingles. Chalo. Now let's do the next question. Identify the condition that is shown in the image. So I'll just zoom the image for you. So when I zoom the image for you, you can see that there is some huge, massive lesion that is present over the genitalia of the patient. And for me, this looks like a cauliflower, isn't it? It can be compared to this vegetable that is cauliflower. And what is this lesion? Is it condyloma lata, condyloma acuminata, Buschke-Lowenstein tumor, or hemorrhoids? So Depaki seems to be very, very confident. That is why she's like C, 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 C. What is it? So I'm getting answer as A, C. What else? B. So now there is confusion over here because there is like answer of A, B, C and everything. See, remember condyloma lata is what you can see in syphilis, especially in secondary syphilis, where you can see that there are flat topped lesions over the genitalia. This doesn't look like a flat topped lesion, so let us rule out this one. Condyloma acuminata, these are genital warts, isn't it? So this can be genital warts, but genital warts, this is like massive lesion that you can see in this MCQ. So let's keep condyloma acuminata also aside. What is Buschke-Lowenstein tumor? Buschke-Lowenstein tumor means these are giant condyloma acuminata. So very big, large size condyloma acuminata is called as Buschke-Lowenstein tumor. And hemorrhoids, all of you know that hemorrhoids doesn't present to you like this. So what is the right answer here? The right answer here should be Buschke-Lowenstein tumor. Please remember, it is a completely benign lesion, so which would require a local surgical excision as well. So this is called as giant condyloma acuminata, which is also caused due to human papilloma virus. Also caused due to human papilloma virus. So now let's go to the next question. A 10-year-old boy, and now this is a question which has been repeated multiple times in the NEET PG. So pay attention to it. A 10-year-old boy presented with a tender boggy swelling of the scalp and positive KOH finding. So if the positive KOH finding is there, we know that this is going to be a fungal infection, right? So all of the following can be seen except, so easily pluckable hair, regional lymphadenopathy, endemic to Kashmir, and can result in scarring alopecia. What is it? Yeah. So Gautam is going into the right approach. So whenever you get an MCQ like this, and if the diagnosis is not mentioned, please tell the diagnosis to yourself. What can be the diagnosis here? The diagnosis here should be Kirion, which is a type of tinea capitis, which is a type of tinea capitis. And Kirion, we get a easily pluckable hair, we get regional lymphadenopathy. This can also lead to scarring alopecia, but the odd one out is endemic to Kashmir. Now, do you know that which is a type of tinea capitis which is endemic to Kashmir? So what is endemic to Kashmir? Yeah, that is another type of tinea capitis which is called as favus, which is called as favus. Okay, so here the right answer should be C, because that is not seen in Kirion, because whereas all the other features which is mentioned in the MCQ can be seen in Kirion. So what is the next question? All are true about lupus vulgaris except long-standing plaque lesion, apple jelly nodules on diascopy, central scarring can be seen, and most commonly arises from the underlying lymph nodes. What is the answer? Yeah, the plucking of the hair by themselves, that is called as trichotillomania. Rashmi. But in this case, in the previous MCQ, what we got is that there was easily pluckable hair, which means as a physician, if you are going to remove the hair of this patient, the patient will not even complain of any pain. We can easily remove them. That is called as chirion. So trichotillomania is a different entity and chirion is a different clinical entity. So now let's see what is true about lupus vulgaris. Yeah. So most of you are answering it as most commonly arises from the underlying lymph node. So please remember what type of cutaneous tuberculosis usually arises from the underlying lymph node, especially over the neck region and all, especially in children. So this is going to be called as scrofuloderma. So this is a feature of scrofuloderma, whereas all the others can be seen in lupus vulgaris, which is the most common type of tuberculosis, cutaneous tuberculosis. Remember, lupus vulgaris, how does it present over the skin, or how does it come as an infection to the skin? The spread in lupus vulgaris is going to be hematological spread. Okay, so that is going to be a hematological spread. It spreads to the bloodstream to the skin. So that is about lupus vulgaris and scrofuloderma. So now let's do this next image. The image below demonstrates the involvement of which nerve in leprosy. So you can see that in this patient, there is a drooping of the eyelids. So which nerve can lead to a drooping of the eyelids? Is it the facial nerve, optic nerve, oculomotor nerve, or a trigeminal nerve? Who can answer? So this finding, we call it as lag of thalamus. Okay, this is a finding which is called as lag of thalamus. So please don't make a mistake. This is a finding that is associated with facial nerve. So lag of thalamus is associated with facial nerve. And in which disease can you see that? You can see that in leprosy. You can see that in leprosy. So I know that this may be confusing because some of you may think that it is optic nerve, some of you may think that it is oculomotor nerve. But please remember, in patients of leprosy, when there is a drooping of the eyelids, this is called as lag of thalamus, and this is seen with the involvement of the facial nerve. So don't worry if any of you is getting it wrong. We are still in the learning phase, right? But I'm sure that if this question comes for the exam, you will not make a mistake now. Okay, now you will remember that this is going to be seen in facial nerve involvement in leprosy. Okay, done. So now let's see. Organism in the image is a causative agent for. So, and this is the image. So this probably is a KOH image of some mites. And what is it? So which is the mite that is shown here? Which is responsible? Is it responsible for pediculosis? Is it responsible for molluscum contagiosum? Is it responsible for scabies or Pityriasis pubis? Very good. So this is associated with scabies because the mite that you can see in this image, this is called as Sarcoptes scabi. This is called as Sarcoptes scabi. Okay. And this is going to be associated with scabies. Yep. And remember what is the most typical skin lesion in scabies? I guess I have a question about it as well. Yes, Dr. Depaki, that is going to be the burrows. Very good. So now let's see the next question. Which among the following STI exhibit the type of alopecia as shown in the image? I'll just zoom the image for you. So what I see here is there is a patient who has developed multiple patchy hair loss, right? So when you see multiple patchy hair loss, is it seen in primary syphilis? Is it seen in chancroid, LGV, or secondary syphilis? Yeah, Nasrina is also giving the name for this kind of a hair loss. So is Gautam and Rashmi and others as well, Dr. Depaki as well. So this is called as moth-eaten alopecia, And this moth-eaten alopecia can be seen in secondary syphilis. And this can be seen in secondary syphilis. So happy to see all those right answers in the chat box. Amazing. Okay, you guys rock. So now let's see the next question. Let's see if you're able to answer this one. A 20-year-old male with milky white, sharply demarcated macules present on the dorsa of the hands. And he has also been on a medication for a thyroid abnormality for 1 year. What's the diagnosis? Is it pybaldism? Is it pityriasis alba? Is it leprosy or is it vitiligo? I'm zooming the image for you. You can see that there is a milky white deep pigmented lesion over the dorsum of the hands. So what is the most likely diagnosis, as it is a 20-year-old male is having some thyroid abnormality, most probably autoimmune thyroiditis, like Hashimoto thyroiditis, right? So now what comes to your mind here? Yeah, this should be a case of vitiligo. Okay, this should be a case of vitiligo. So now let's go to the next question. A 35-year-old lady develops a brown macular lesion over the bridge of the nose and the cheeks following to exposure to light. What is the probable diagnosis? I'll zoom the image for you. Such a typical image, right? You can see a dark brown, hyperpigmented patches over the nose as well as the cheeks of the patient. So when do you find these kind of brownish patches? So when do you find these kind of brownish macular lesion or patches over the skin? Yes, so this can be seen. So again, there is a problem here. So some of you are answering it as wrong as well. So whenever you find brown patches, always go for melasma, because whoever is answering it as C, that is SLE, in SLE, all of you have seen malar rash. But what is the color of a malar rash? Is it brown or is it red? So please remember, malar rash is going to be erythematous. So it should be a red colored rash which you can see over the skin, because there is nothing wrong in your thought process, because malar rash can be seen as a photosensitive rash as well. But here the catch is brown. Okay, the brown means answer is melasma. Red means the answer could have been SLE. And Dr. Dharmesh, very good. If you find only lesions over the tip of the nose or over the nose without the cheek involvement, especially if the question says there is a history of fever, then you can think about chikungunya. Okay, then you can think about chikungunya as well. Clear? Very good. And this sign is called as the chick sign in chikungunya. Excellent. So now let's go to the next question. So in this next question, what you can see is identify the lesion. So I'll just zoom the image for you. I can see that this is a kid, it's a baby who is having some bluish discoloration over the shoulder area. So whenever you find a blue colored discoloration over the shoulder area, do you call it as nevus of Ito, nevus of Ota, Mongolian spot, or hypomelanosis of Ito? So I can see many of you answering it as Becker's nevus. Okay, many of you are answering it as Becker's nevus. But unfortunately, in the option Becker's nevus, Heini, isn't it? So here the right answer should be nevus of Ito. Okay, please remember, blue discoloration over the shoulder is going to be nevus of Ito. Nevus of Ito. Becker's nevus, I appreciate your thought, because Becker's nevus can also be seen over the shoulder area. But what is the type of lesion that you can see? Here you can see brown patches, isn't it? Brownish hyperpigmented patches can be seen over the shoulder area. That can be Becker's nevus. Okay? And ota means that can be seen over the face as well as the eyes. That is called nevus of ota. And Mongolian spot, all of you know that this can be seen in children, where you can find these kind of blue color discoloration over the buttocks area, over the thighs area and all. Okay, so that is how. So please don't make a mistake on the day of the exam. So now let's see the next question. Identify the infective disorder of the skin as shown in the image. So this is the image for you. Okay, what you can see in this image is there are multiple hypopigmentation over the face. See, Rohit, Tyndall effect means, I'll just go back to the previous question. So some of you has got a question. So what happens is, the melanocytes, they are present in the stratum basale. These melanocytes, they are derived from the neural crest. So what happens is, during this journey from the neural crest to the stratum basale, these melanocytes sometimes may get trapped in the dermis. So this is called as dermal melanocytosis. So when the melanocytes, when they get trapped in the dermis, then the effect that you can see over the skin is called as Tyndall effect. And because of this Tyndall effect, the skin lesions, they appear as blue in color. Okay, all these are seen in ceruloderma, where you get a blue color discoloration of the skin. Okay, where you get a blue color discoloration of the skin. And now you can see that. Oh, that's amazing, Shiv, that you got your PG in PGI Chandigarh. So amazing, amazing. Yeah? And thank you so much for joining. Okay, let's make this learning a wonderful journey. And now you can see one of you was asking what is hypomelanosis of ITO. So what is hypomelanosis of ITO? This is a condition which follows the Blaschko lines. Okay, this is a condition which follows Blaschko lines. So these are one of the lines that you see over the skin. And in hypomelanosis of ITO, you can see a Chinese character pattern in the skin. Okay, we can see a Chinese character pattern in the skin. Okay. So may I know which specialty did you join in PGI Chandigarh Shift? Is it dermatology or something else? You can see all of you are congratulating you as well. Amazing. Nice to have you in the session. So now let's go to the next one. So can you answer this question, all of you? See, this should motivate others, right? So somebody is in PGI Chandigarh now who joined this Jan session. Okay, that is in surgery. Amazing. Great. Good. Best of luck for you. And we are going to have more doctors who are going to crack the INI-CET exam soon, right? So now let's see this question. What is the infective disorder that you see? Is it verruca plana? Is it pityriasis alba? Is it tuberculoid type of leprosy? Or is it TB scrophaloderma? So yes, so verruca plana means this should be warts, doesn't look like warts. Pityriasis alba can present like this, which I agree. But see the key point here. The question says infective disorder, which means pityriasis alba is not a infective disorder. So please don't answer it as pityriasis alba, क्योंकि ये एक infective disorder है ही नहीं. And then we are left with tuberculoid leprosy and TB scrophaloderma. TB scrophaloderma, it usually appears with some swelling around the lymph node, right? Scrophaloderma, swelling around the lymph node, which arises from the lymph node. That is also not possible. So the most closest answer which can be right here is a tuberculoid type of leprosy, isn't it? Tuberculoid type of leprosy. So you have to be very, very sharp when it comes to doing the MCQs, because some of the images and the question can be deceiving, because many of you may think that this is pityriasis alba. Just one word in this MCQ, infective, has changed the answer, isn't it? So that is all about this question as well. So now let's see the next one. Identify the condition that is given below. So what you see here, is it ichthyosis vulgaris? Is it X-linked ichthyosis? Is it harlequin ichthyosis? Or is it a collodion baby? And I'm zooming the image for you. So in this image, I can see that the entire skin itself is not formed, right? And you can see that there is some armor like encasement of the chest. There is eclabion, isn't it? So there is no proper development of the mucosa of the eyes or of the lips. So what is this? Most of you are answering it as C. This is called as the harlequin baby or the harlequin ichthyosis. Very typical spot diagnosis, and I can see the entire chat box is filled with C. I guess nobody is having a doubt whether it is harlequin ichthyosis or not. So now let's see the next question. A boy presents, one moment. So a boy presents with a history of a severe sunburn only few minutes after exposure to the sunlight. There is freckling over sun exposed area, dry skin, some pigmentary changes in the skin as well. What is the most probable diagnosis? So you can see that there are sunburn, matlab there can be a severe photosensitivity. There is some freckling over the skin, dry skin, matlab cirrhosis is also seen, some pigmentary changes is also seen. So when you put all these things together, what should come to your mind? Yes, I'm getting maximum answer as B in the chat box. So this is called as xeroderma pigmentosum, right? Cirrhosis means dry skin, derma is skin, pigmentosum means hyperpigmentation. So all these can be seen together, which is a autosomal recessive condition. So this is going to be xeroderma pigmentosus. Another very easy thing. So let's see how many of you are getting it right. Which mineral deficiency can lead to the following condition? And I'll zoom the image for you. So in this image, what I can see is wherever there is an orifice, like around the nasal orifice, there is a rash. Around the oral orifice, there is a rash as well. So what is this periorificial dermatitis? Periorificial dermatitis, very typical finding related to, yes, this is related to zinc deficiency, which is also, and the diagnosis should be acrodermatitis, and the diagnosis should be acrodermatitis enteropathica, acrodermatitis enteropathica, okay, which happens due to zinc deficiency. This is also an autosomal recessive condition. It's also an autosomal recessive condition. So now let's just read the next question. A 3-year-old child presents with a hypopigmented lesion which is present since birth. So these kind of things should actually be the eye opener for you, that there is a lesion and the lesion is present since birth. You should not miss on these kind of key words in the MCQ. On diascopy, the lesion appeared not to blanch. There is no blanching. Which is the probable diagnosis? So Ipsita Pramanik says B, nevus anemicus. How many of you agree with that, or do you have another answer? Random Max says C. Debaki says B. Kamal says B. So now let's see this thing. See, what I can see here is there is a well demarcated lesion over the skin, and when you are pressing the skin with a glass slide, there is absolutely no change. No change to this lesion means this can be a pigmentary defect rather than a capillary defect. So if it is a pigmentary defect, what is the name? The name is nevus depigmentosus. Okay, Ishfaq is answering it right, Dr. Dharmesh as well. But whoever has got it wrong, so no need to feel disheartened. It is all fine. So please remember, अगर कोई blanching नहीं है, then it should be a pigmentary defect. Pigmentary defect means it should be nevus depigmentosus. Whereas since many of you said nevus anemicus, anemicus is going to be a capillary defect. And if it was a capillary defect, what is our expectation? Our expectation is that this lesion should blanch on diascopy. Should Blanch on diascopy. Yes, this image is showing that when we are pressing with the diascope with a glass slide, that test is called as diascopy. So this test is called as diascopy. There is no blanching under diascopy, so the answer is going to be nevus depigment. Okay, so now let's go to the next question. Identify, oh my god, so sorry, I don't have the skin lesion here, so we will just move to the next topic. So a 45-year-old male suffering from ulcerative colitis presents to the clinic with an ulcer on the anterior aspect of the leg. What is the most probable diagnosis? Pyogenic granuloma, Marjolin's ulcer, pyoderma gangrenosum, venous ulcer. Wonderful question, right? So here this question says patient is having ulcerative colitis, and what is the ulcer that you can see in the skin which is associated with ulcerative colitis? And this is the image. This is the image for you. Yes. So I can see most of you answering it as C. Yes, very good. This is going to be associated with pyoderma gangrenosum. The pyoderma means pus forming. Gangrenosum means gangrenous skin. Please remember, this is also a misnomer. So what is pyoderma gangrenosum? It is a neutrophilic dermatitis. And this neutrophilic dermatitis, this is associated with rheumatoid arthritis or irritable bowel disease or hematological malignancies or hematological malignancies. So that is how this can be seen in association. So if tomorrow for your exam, if the question says a non-healing ulcer is there which is associated with rheumatoid arthritis or associated with irritable bowel disease or hematological malignancy, in all these cases your right answer should be pyoderma gangrenosum. So your right answer, it should be pyoderma gangrenosum. So now let's go to the next question. The finding shown in the image may be seen in. So where do you see this kind of finding? I'm zooming it for you. Very, very common. And this has been asked, I guess, in the last NEET PG exam also we got the same question. So what is this? You can see there is some hyperpigmentation and the skin has become velvety as well. Velvety hyperpigmentation. So where do you find velvety hyperpigmentation? Yes, very good. The diagnosis should be acanthosis nigricans. So in acanthosis nigricans, the type of velvety hyperpigmentation that you see, and this can it be seen with adenocarcinoma of the stomach? Can it be seen with obesity? Can it be seen with Bloom syndrome or all of the above? Yes, the answer here is all of the above. So we know that it is very commonly associated with obesity, PCOS, metabolic syndromes, and etc. So along with that, even rarely malignancy, Bloom syndrome, all those things can also be associated. So here the right answer should be all of the above. So let's see the next question. A 60-year-old male patient presents with history of a slowly growing pearly nodule with a prominent arborizing vasculature and ulceration. Located in the inner canthus of the left eye, what is the most probable diagnosis? So this is the image that you can see. So what you see in this image is that there is a rolled up border of this lesion. In the center, you can see some proper arborizing vasculature. We can also call it as telangiectasia. So in which disease? Is it squamous cell, malignant melanoma, Bowen's disease, or basal cell carcinoma? Yes. So this is seen in basal cell carcinoma. Very, very typical image. Okay. So you can see a rolled up border with a central telangiectasia. Always think about basal cell carcinoma, which is the most common type of skin malignancy. So it is the most common type of skin malignancy. अब ये क्या है? This is also a part of skin malignancy. What is the condition that you can see? So what you see here is, I can see that there is a hyperpigmented lesion and the lesion is asymmetric. There is an irregularity of the border. Some part of the lesion is darker in color. Some part of the lesion is lighter in color. So all these things, if I evaluate it with A, B, C, D, E algorithm, what is the diagnosis that I will reach up to? Yes, this is an image of malignant melanoma. Asymmetry, border irregularity, color variation, diameter more than 6 mm, and the lesion is evolving in the size, color and shape. So all these are very typical for malignant melanoma. Rohit, BCC is actually a skin malignancy. It is not a benign cancer. It is a malignant condition of the skin. But the only good thing about BCC that it is not going to be, very, very aggressive. So it has a very slow course of the disease. So it can be invasive to the nearby skin, but it has a normally a slow course of disease. Okay, but still it can be considered to be a malignancy of the skin rather than a benign condition. So this is the next question. A 30-year-old male presents with sudden eruption of multiple seborrheic keratosis. It is rapidly increasing in the size as well as the number. So usually क्या होता है कि seborrheic keratosis, we may see that elderly patients is having one lesion or a couple of lesions together. But when you get multiple eruption of seborrheic keratosis, this is going to be a sign because this is very closely associated with GI adenocarcinoma. So yes, what is it? So most of you are answering it right in the chat box. That is Leser-Trelat sign. Excellent. So when there is a sudden eruption of multiple seborrheic keratosis, where you get these kind of brownish colored hyperpigmented plaque lesions over the trunk, you have to refer the patient to surgery to rule out GI adenocarcinoma. Okay. So here the right answer is going to be Leser-Trelat sign. So now let's see the next question. There is a male who does gardening as a hobby and he comes to the clinic with complaints of multiple nodular lesions which is arranged in a pattern as seen in the image. Now what is the pattern here? You can see that there are multiple nodular lesion and the entire nodular lesion, they are arranged linearly, isn't it? They are arranged linearly. So this is because they run along a lymphatics and this pattern is called as the sporotrichoid pattern. And in which disease do you find them? We find them in sporotrichosis. And why is there a mention that there is a male patient who is doing gardening? Gardening as a hobby, because this disease is also called as the rose gardener's disease. This is also called as the rose gardener's disease. Clear? So now let's go to the next one. A young male comes to the clinic concerned about a swelling over the neck without any symptoms. The lesion was non-tender, easily movable on examination. What is the probable diagnosis? Yes, Dr. Depanki, in sporotrichosis, you also get to see the asteroid bodies as well. Excellent, very good. So, what is this? Previous question. See, in the previous question, to answer about the other options, mycetoma means Madhura foot. In Madhura foot, the patient would have come with a large swelling of the ankle. यहाँ पे कोई ankle swelling नहीं है. Chromoblastomycosis, this usually comes like a cauliflower-like exophytic lesions in the leg. So this doesn't look like a cauliflower lesion क्योंकि chromoblastomycosis में we can also see copper penny bodies as well, okay, in histopathology. And actinomycetoma means this is again Madhura foot, but here the causative organism is not a fungus. Instead, this is caused due to bacteria. So when Madhura foot is caused due to bacteria, we call it as actinomycetoma. So is that clear? Okay. So what is the answer for this question? There is a young patient who is a very easily movable lesion. So whenever you find a easily movable lesion, which is usually made up of fat cells, this is called as lipoma. Okay, what is lipoma? Lipoma is going to be a benign tumor of fat cells. It can be a benign tumor of fat cells. So now let's go to the next question. Identify the condition that is given below. Is it herpes genitalis? Is it bovinoid papillosis? Is it anogenital warts or Buschke-Lowenstein tumor? So just see this. What I can see here is we can suppose that this is the genitalia of a patient, and I can see that there are multiple very small erosions. That is because probably the patient would have had multiple vesicles, and these vesicles must have now ruptured to form erosions. So what is this? Is it herpes, bovinoid papillosis, anogenital warts? Yes, very good. So this is going to be herpes genitalis, right? So this can be most commonly caused due to HSV2, which is the most common cause of genital ulcer disease, right? So here this should be herpes genitalis. So now let's go to the next question. A 3-month-old male infant developed a furuncle. So when I see a furuncle, I immediately tell myself ki furuncle is a bacterial infection caused due to Staphylococcus aureus. It is caused due to Staph aureus. And after few days, what has happened is he developed blistering and peeling of the skin, and there were no mucosal lesions. So when I zoom this child, you can see that the child's skin, it looks like a burns patient. The entire skin has peeled off. So there should be a lot of distress. What is the likely diagnosis? Yeah, everyone is answering in the chat box as staphylococcal scalded skin syndrome. क्योंकि यहाँ पे क्या हो रहा है? Furuncle, which is caused due to Staphylococcus aureus, this staph is going to release toxins in the blood. So once it releases toxins in the blood, the patient can present with massive peeling of the skin, and this massive peeling of the skin without any mucosal involvement is called staphylococcal scalded skin syndrome. So very good. Yes, it's also called as a Ritter's disease or the pemphigus neonatorum. So now let's see another question. I would say that this is one question which is the repeat mode, especially in NEET PG exam. So let's see what is this question saying. 8-year-old child presents with erythematous, itchy lesions over the flexural aspect of the elbow. Mother is a known case of asthma. What is the likely diagnosis? So here what you see, there is itchy lesions on the flexural aspects, and there is a history of mother. Why? Just to show that there is a family history. Okay, just to show that there is a family history of atopy, because there is a family history of asthma. What's the diagnosis? The diagnosis here should be atopic dermatitis. The diagnosis should be atopic dermatitis. So whenever in atopic dermatitis, what do you see? We always see a dry skin. So this dry skin, where do you see this dry skin? In small crawling infants, you see them over the extensor surface and as well as the face. Whereas in child and as well as in adults, we see it over the flexural aspects as well. Okay, that is called as atopic dermatitis. So now let's see what is this next question. So in next question, you can see there what is a spot diagnosis. And here I can see that there are multiple lesions which are, almost annular or rounded lesions that can be seen. Is it seborrheic dermatitis? Is it nummular dermatitis? Or is it contact dermatitis or atopic dermatitis? Very, very good. Yes, Dr. Zabaki, atopic triad can be seen in atopic dermatitis, but not necessarily in everyone. Okay, not necessarily in everyone. So yes, here all of you are getting it right. This is called as nummular dermatitis because you get a coin-shaped eczema here. Because we get coin-shaped eczema here. Okay, so coin-shaped eczema is called as nummular dermatitis. So let's see the next image. What is the likely diagnosis? Is it acne vulgaris, rosacea, melasma, or SLE? And I'll just zoom it for you. So when I zoom this, what you see here on the screen is there is something over the face which involves the entire part of the face, including the nose as well, isn't it? The entire part is involved. And now here, what I can very clearly see is there are dilated blood vessels as well. So these dilated blood vessels are called as telangiectasia. So what should be the diagnosis here? Since I can see erythema plus telangiectasia, did you learn that there is some telangiectasia in SLE? No. In melasma, what should be the color of the skin? In melasma, the color of the skin should have been brown in color. So in acne vulgaris, do we get something like this? No. In acne vulgaris, we will get polymorphic skin lesions. Skin lesions can be seen, right? So here the right answer should be rosacea because erythematotelangiectatic type. So it's very, very important that you read the skin. So when you see this image, you can see that there are multiple telangiectasia that can be seen here and there. So all these telangiectasia, this is seen in a condition called as rosacea. It's seen in a condition called rosacea. So I guess that is it about this discussion because I just added maximum number of images. We just tried to make it as an MCQ discussion today, and it was a very, very amazing crowd because you guys were very interactive, and that is the reason where we were able to, cover these many topics in one shot. Okay. And if there is anything that I would like to help you with, if there is any queries, do let me know. I'll be happy to answer your queries. So yes, Dharmesh, because we are adding multiple topics. So regarding pemphigus and all, see, in case of pemphigus, what you can see is if it is pemphigus vulgaris, you will be always given a mention key there is involvement of the oral mucosa in the and followed by some flaccid lesions over the trunk. So that is how you can reach out to the diagnosis of pemphigus vulgaris. Okay. So thank you so much, all of you. Please, one session for one-liners. Definitely, we'll try to have a quick, rapid flow one-liner session as well. So thank you so much for listening to the lectures. So we'll have more lectures like this coming up in the coming days. And I wish you all the very best. Yes, the Dharma size should be enough, especially the rapid revision videos or the entire notes. Okay, that would be sufficient for your exams. Okay, so thank you so much, all of you. So I look forward to having more sessions with all of you and happy learning and wish you all the best for the upcoming exams.